So this is obviously you are asking two difficult questions in a certain way in one fell swoop. The first thing is the treatment algorithm, right? In contrast to other conditions in multiple sclerosis, there has been a certain lack of kind of uniform treatment algorithms or treatment recommendations to a degree. Because if you really look at what has come out of the MS Society, the Academy of Neurology, and the International MS Alliance, it is clear that patients with multiple sclerosis should start on effective treatment right at the diagnosis. So from that point of view, probably our traditional approach where we start with one medication, then with another medication, then with a third medication, really is not the most optimal approach to looking at patients. And it's particularly when we are looking out from the condition of secondary progressive MS, because in a certain way, you could look at secondary progressive MS as the failure of prior treatment approaches, or maybe also the failure of the patient to adhere to treatment, or the failure of the patient to present at the earliest possibility to a practitioner and to introduce. When I use the word failure, obviously maybe a little bit too harsh a word. Maybe a better word is the missed opportunity for all of this. You know, I sometimes, as an MS physician, envy our friends from rheumatology, where essentially in rheumatoid arthritis it says, thou shalt treat patients with rheumatoid arthritis to radiographic silence within 6 months of diagnosis. Unfortunately, this is more complicated in multiple sclerosis. The timelines are a little bit longer. In multiple sclerosis, we have other challenges. Traditionally, we use the MRI to look whether a patient has continued disease activity. Our MRIs that we are currently using are good in assessing white matter disease activity, so disease activity in the part of the brain that is significantly the highways between centers that think or coordinate, the gray matter or the deep gray matter nuclei. Unfortunately, our current technology with MRIs doesn't necessarily show us the gray matter lesions unless we use experimental or investigational techniques that are not available to the average practitioners in the clinic. So in a way, we decide that somebody is inflammatory, is controlled on the basis of something that doesn't really tell us what happens to the thinking part of multiple sclerosis. And so we have a biomarker in the MRI, but the biomarker is not perfect. More recently, there have been other biomarkers looked at. One of them is neurofilament light. Neurofilament light is essentially shed from neurons when they get injured or when they die. An important advance has been that neurofilament light can now be measured in the serum, so it's no longer necessary to do a lumbar puncture. At the same time, while this is a significant progress, in order to have neurofilament light in the serum, nerve cells have already been destroyed, or nerve cells are already dying, meaning that we are not necessarily looking at a prospective feature, but we are already looking to a responsive feature because nerve cells have been injured. And so what we really miss in multiple sclerosis at this point in time is a marker that will tell us where an individual patient is gonna go. What is actually gonna happen in this patient? Who is gonna have an attack in the next 6 months? It will be very interesting to see when all the research or many more research studies are in to see where neurofilament light will pan out. Because one thing is also a challenge is that other conditions also increase neurofilament light. For example, Alzheimer's disease with destruction of brain structures increases neurofilament light. Even in diabetes, for example, or as we age, neurofilament light levels go up. So it is an interesting measure, but we need to learn how we use it. I sometimes think of the neurofilament light as a biomarker more like the erythrocyte sedimentation rates that we use in other conditions, the ESR. It tells you that something is wrong, but it doesn't tell you why it's wrong. And so, yes, we don't necessarily have prognostic biomarkers. The best prognostic biomarkers that we have currently is MRI and potentially neurofilament light, but our techniques need to improve over the years in order to really harness the full benefit of potentially individualizing cares to the most optimal fashion in a given patient.